Hey everyone, welcome to This Explainer. Today, we're taking the incredibly tense, fact-heavy world of clinical tuberculosis pharmacology and transforming it into a high-octane study summary. If you're prepping for your medical board exams, you already know that TB drugs are an absolute favorite for examiners. So we're going to strip away the fluff and focus exclusively on the high-yield mechanisms in the critical side effects you need to totally dominate your test. Let's get into it. Here is our roadmap for test day. We'll start by conquering TB pharmacology overall, then hit the first-line heavy hitters, look at the second-line backup bench, dive into critical drug interactions, and wrap it all up with a final board review. All right, part 1, conquering TB pharmacology and building that mental map. So tackling TB pharmacology on the boards means you gotta focus sharply on mechanisms and those big red flag side effects. Examiners, they don't just want the drug name. No way. They expect you to instantly associate that name with its specific molecular target, the gene responsible for its resistance, and its absolute most dangerous toxicity. It's all about building a reflex, right? When you see a specific symptom in a vignette, you need to immediately know exactly which drug is the culprit. Let's jump right into part 2, the first-line heavy hitters. This is your core regimen. We're starting with isoniazid, or INH. What's incredibly high yield to remember here is that it's actually a prodrug. It literally requires the mycobacterial CAT-G catalase peroxidase enzyme just to wake up and become active. Once it's activated by that CAT-G gene, it goes to work aggressively blocking mycolic acid synthesis, basically ripping apart the mycobacterial cell wall. But if the bacteria happen to mutate that CAT-G gene or the NHA promoter, isoniazid becomes totally useless. But that efficacy comes at a steep price. Isoniazid aggressively targets the liver and the nerves. You've got to monitor for idiosyncratic hepatitis, and since it actively interferes with pyridoxine, giving prophylactic vitamin B6 is an absolute must to prevent peripheral neuropathy. Oh, and keep a really close eye on vignette patients described as NAT2 slow acetylators. They metabolize the drug much slower, which means higher blood levels and a drastically increased risk of all these toxicities. Next up in our first-line defense is the rifampin family. And this right here perfectly illustrates a classic, absolutely favorite trap for examiners, pitting general-use rifampin against its cousin, rifabutin. See, rifampin is a massively potent inducer of the CYP450 system in the liver. It just revs the whole thing up, accelerating the breakdown of a ton of other medications. So if you've got an HIV patient taking protease inhibitors or NNRTIs, rifampin is going to completely destroy their antiviral drug levels. In that specific scenario, you absolutely must switch to rifabutin because it's a much less potent inducer. Take a look at the distinctions between the rifamycin family members here. They all inhibit the RNA polymerase beta subunit, which, by the way, is encoded by the ARPO-B gene, and they all cause harmless, but let's be honest, pretty startling orange-red body fluids. We're talking tears, urine, the whole 9 yards. But pay attention to the differences. Rifabutin carries a unique risk of uveitis and yellow skin discoloration, whereas rifapentine has this really long half-life, making it the absolute go-to for weekly dosing regimens in latent TB. Okay, let's move on to pyrazinamide and see how it builds out our arsenal. Just like isoniazid, pyrazinamide is a prodrug, converted by pyrazinamidase. But its real superpower? Its environment. It is active almost exclusively in a highly acidic pH, so less than 6.0. This lets it dive deep inside phagocytes and granulomas to hunt down and destroy those slowly replicating organisms just hiding out in those harsh, acidic environments. And honestly, that's exactly why it lets us shorten standard TB treatment from 9 down to 6 months. That being said, pyrazinamide is incredibly tough on the body. It carries a severe risk of hepatotoxicity. And even more uniquely testable, it blocks renal urate excretion. So the second you see a board exam patient on a TB regimen who suddenly develops severe joint pain or arthralgia, your immediate thought has to be hyperuricemia and potential gouty arthritis triggered by pyrazinamide. Rounding out our first-line core is ethambutol. Now, unlike the others we've discussed so far, ethambutol plays a unique role because it's purely bacteriostatic, not bactericidal. It works by inhibiting arabinosyl transferases. Those are the enzymes coded by the MB gene, which effectively halts arabinogalactan synthesis right at the cell wall. So the absolute crucial point you need to know for ethambutol is its terrifying hallmark toxicity, optic neuritis. This shows up as decreased visual acuity, central scotomas, and, very classically on the boards, the loss of red-green color vision. Guys, this is a massive, life-threatening intervention trigger. At the very first sign of red-green color vision loss, you stop ethambutol permanently, no questions asked. Baseline and monthly visual exams are simply mandatory here.
Moving on to part 3, second-line drug profiles. Let's look at the backup bench.
When those first-line drugs fail us, maybe due to resistance mutations like CAT-G or RPOB, or just unbearable toxicity, we have to turn to the backup bench. We split these up into groups. For Group A, preferred drugs, examiners will absolutely test your awareness of specific red flags. Linezolid, for instance, is notorious for causing bone marrow suppression. Think thrombocytopenia and anemia, along with peripheral and optic neuropathy. Then you've got betaquilin, which inhibits the mycobacterial ATP synthetase pump. Its defining highly testable danger, severe QT prolongation on an ECG.
Now, moving to Group B, the side effects get incredibly specific. If a question describes a patient suddenly experiencing psychosis, suicidal ideation, or seizures, cycloserine is your primary CNS culprit. On the flip side, if a patient presents with a very persistent brick red or purple skin discoloration, you instantly know they're taking clofazimine. That's a dye-based drug with a massive 70-day half-life. And within the aminoglycoside class of second-line drugs, here is another absolute rule you need to sear into your brain right now. Streptomycin is strictly, categorically contraindicated in pregnant patients. It binds the 16S rRNA, and sure, it causes ototoxicity and nephrotoxicity in anyone, but in pregnancy, it leads to irreversible 8th cranial nerve damage and permanent deafness in the fetus. Just don't do it.
All right, part 4, critical drug interactions. These are your major red flags. We've reached the climax of our explainer. These are the critical drug interactions board examiners literally dream about testing. You can't just know these drugs in isolation, right? You have to know how they behave when thrown into the mix with a patient's other meds. So let's test your clinical reflexes with a classic board scenario. What is the dangerous physiological result of mixing our first-line drug isoniazid with a common blood thinner like warfarin? Take a quick second to think about those liver enzymes. Well, if you remembered that rifampin is the inducer, you should definitely remember that isoniazid is a potent CYP450 inhibitor. Because it inhibits those metabolic pathways in the liver, it completely blocks the breakdown of warfarin, phenytoin, and benzodiazepines. The result? Those drug levels dangerously spike in the bloodstream, leading to massive bleeding risks or acute toxicity. And right here, these are your strict do not mix lethal combinations. Never, ever combine pyrazinamide and rifampin for latent TB. The risk of fatal hepatotoxicity is just way too high. If a patient is on linezolid and pops an SSRI antidepressant, you're staring down a life-threatening serotonin syndrome. And if you stack betaquilin with moxifloxacin or clofazimine, you're layering drugs that all prolong the QT interval. That makes continuous ECG monitoring an absolute matter of life and death. Finally, part 5, the final board review. Let's really test your knowledge. To wrap up this explainer, let's lock in everything we've just covered with a challenging, high-yield, board-style takeaway question to test that new mental map of yours. Imagine this vignette. A patient being treated for multi-drug-resistant TB suddenly develops a dangerously prolonged QT interval on their ECG. Upon examination, you also notice they've developed a persistent brick-red discoloration on their skin. Think carefully about those vivid side effect associations we covered earlier. Can you identify the 2 specific drugs causing this exact presentation? Did you get it? If you instantly recalled clofazimine as the dye responsible for that brick red skin discoloration and recognized that both bedaquiline and clofazimine are major culprits for QT prolongation, then you, my friend, are absolutely ready to conquer your pharmacology question banks. As you continue studying, I want you to ask yourself, when a patient presents with an impossible web of drug side effects, are you merely treating the symptom, or are you catching the biochemical culprit hiding right there in their prescription list? Keep building those mental maps, stay curious, and we'll see you in the next explainer.